Now in this second video of birthday nightmare case, I performed corneal tear repair under local anesthesia. When the globe is open, try to inject as less peribulbar local anesthetic as possible. So I injected 1 ml superiorly and 1 ml inferiorly to prevent intraocular contents extrusion. Now after and you can see the extent of the corneal wound. It was from 6 o'clock limbus inferiorly going superior temporal in an arc like fashion up to the level of 3 o'clock in ending in the peripupillary area. Now wound is fresh and from clean fruit knife, so no exudative or infective membrane is present in the wound. The wound have got sharp edges and clear margins and healthy iris wound incarceration. So I made site port at 9 o'clock with 15-degree phaco knife. Anterior chamber was irregularly formed, so deepened it with viscoelastic. You can see I am trying to put viscoelastic. And now with the help of a dialer, I am trying to release the incarcerated iris from the wound. Now it would release iris, but as the intraocular pressure is raised due to viscoelastic and open wound, it will again and again move out. So after a few unsuccessful attempts with the help of a dialer, I came out of the anterior chamber because the iris is savage and until the wound is open. Now always remember the rule of a corneal or corneoscleral wound. Start corneal suturing with limbus suture because limbus to limbus alignment is essential step of corneoscleral suturing to avoid the irregular margins, avoid corneal traction and tension and irregular astigmatism. Now first suture is always difficult and challenging because of savage iris. So despite my care that it shouldn't come into the 10-0 nylon suture, I took iris in bite, but I was sure that later on I will take care of. After first suture, now with the iris repositor, I am repositing the iris inside the eye, and now iris is obeying a little bit. So I was able to put iris inside the eye with the help of iris repositor. But as I move the iris repositor out of the iris also comes out. So I started the second suture, and while my assistant was holding iris repositor in place, so second suture was also not very easy because iris was again and again coming out. So even with a little bit of iris tissue was taken in the second suture as well. But in my mind I thought that let me first complete the wound suturing, and then with the help of a dialer, I will release the iris at the end. So these are just regular interrupted sutures, 10O nylon sutures that we perform after routine conventional cataract surgery. After two successful corneal sutures, now iris settled inside the eye peacefully, and rest of the sutures were very easy to perform because now gel also stayed in and there was a gap between the iris and the corneal wound. Now look at the direction and placement of the 10O nylon needle. It should be 60% deep into the corneal stroma, and with practice you can smoothly go in from one side of the wound and come out on other side without the help of a corneal forceps. But these things come with practice, so make lot of practice, prepare a lot of traumatic corneoscleral sutures, and then your surgical skills will refine. Now I have put viscoelastic and iris stayed in. Look at the direction. I am not taking the help of corneal forceps. So after securing the corneal wound with enough sutures, you can see how I apply the sutures, and these sutures should be on the tighter side rather than on the loose side, because tight sutures when you release the corneal tension will become normal, but with loose suturing there is no cure. Now I am filling the gaps between these sutures. Always use a new 10O nylon suture with a sharp needle to minimize the damage to the already compromised cornea. And now after putting the viscoelastic, now I am trying to release the iris from the first two sutures, and you can see that I had to apply a lot of force. Now one iris is released from one suture, and now from another as well, but so I am now succeeded in releasing the iris from the sutures, but iris is a highly vascular structure, so a vessel is damaged resulting in high FEMA. Now to give pressure tamponade, I put gel in anterior chamber, but as I removed the gel, iris again started bleeding. So with IA cannula at bleeder, I am applying the pressure and vacuum. You can see with the aspiration. In aspiration mode, I have firmly caught the bleeder and now it has stopped bleeding. So these are the two ways to stop iris bleeding. Now the iris is totally released from all corneal sutures. At the end, I am securing the paracentesis port with one suture so that was a corneal tear repair under local anesthesia in a birthday nightmare case, and I am now burying this knot. Now I am putting a subconjunctival antibiotic and steroid injection. Now I am putting the air. It should stay and it will tell you that the anterior chamber is well formed, and in the next session I will perform cataract surgery in this patient. Thank you very much.